Hello, everyone. Thank you so much for joining us here tonight for our first of 7 CE meetings that we'll be doing the last Tuesday of every month between now and September. I'm really honored to be able to be here tonight to provide the CE for you guys on behalf of Vets Pets. I know a good handful of you. Those of you who I don't know, my name is Dr. Paige Harrington, and I serve as the Medical Director of Emergency and Referral Services for Vets Pets. We love doing these CEs, and we really look forward to being able to do them in person. Fingers crossed, maybe for the fall. Housekeeping for tonight, everyone's cameras and audios are turned off. If you have any questions, go ahead and type them at the bottom of your screen into the Q&A section, and at the end, we'll go over all the questions as a group. This is our first Zoom meeting as a big group like this, so we hope that it's seamless for you, but if it's not, please be patient with us as we work out the kinks. And the certificate for tonight will be emailed to you by the end of the week to the email that you signed up with. And now I'll pass over the screen to Dr. Sonia. She's going to be introducing Dr. Spodnik and Dr. Brady for you. Dr. Sonia and I worked together to start Points East, what is now almost 6 years ago. And we've worked really closely together and are really proud of where we are today. And thank you all for attending tonight.
Thank you, Paige. Thank you. I am honored to introduce Dr. Gary Spodnik and Dr. Robert Brady, 2 of my close colleagues. Dr. Gary Spodnik graduated from Oklahoma State University College of Veterinary Medicine in 1985. He completed a surgery residency at Tufts University School of Veterinary Medicine in 1991. He was an assistant professor at North Carolina State University's College of Veterinary Medicine from 1991 to 1996. And he is one of the founding members of the Veterinary Specialty Hospital of the Carolinas, where he worked for over 20 years. In 2019, Dr. Spodnik joined the Vets Pets family, working at Wake Vet Hospital and Urgent Care. Dr. Robert Brady graduated from St. George's University School of Veterinary Medicine in 2016. He completed his surgery residency at Memphis Veterinary Specialist in 2020. And he has joined the Vets Pets family, working at Wake Vet Hospital and Urgent Care, and also at Points East Veterinary Specialty Hospital. Thank you, Dr. Spodnik and Dr. Brady, for the CE entitled Look Before You Leap.
All right. Thank you all for joining. My name is Robert Brady. It's my first time with a Zoom meeting, so hopefully I'm not too distracting in your cameras, because I tend to, in person at least, move around a lot and point and all that good jazz. So the goal of tonight's CE is going to be to discuss, basic surgical oncologic principles and help guide you guys as you're making some of the decision processes within your own hospitals to ultimately hopefully lead to better outcomes and, realistic expectation for all of our patients. And so we'll start off with a little bit of history, because it's always fun to kind of figure out, where we've come from. And one of the founding fathers of the founder of scientific surgery, as he's called, John Hunter, came across on some of our research, and he's a really interesting fella. I could probably talk for an hour about him, but some of the key things is he was born in the 1700s, and he became a surgeon, but he had no real formal training in doing so. He was just really able to analyze things and, try to make correlations, why this happened, why that happened. But his brother was an obstetrician and an anatomist, and he spent 11 years in his lab just studying the human body, and ultimately through a lot of just trial and error, became a well-renowned surgeon in human medicine. And he was one of the first people to advocate for pathology. Now, pathology has come a long way from back then, but figuring out, why I'm doing this surgery, the effects of this surgery, how inflammation plays a big role in surgery, as he did a lot of started out with a lot of war injuries, knife wounds, bullet wounds, and he was kind of one of the first people to associate inflammation with both those injuries as well as surgical inflammation that came along. And he was actually one of the first guys to identify metastasis. One of his well-renowned subjects was a gentleman with osteosarcoma of the thigh. And during his, dissection and necropsy, he was able to identify very similar lesions in the lung. So he was kind of one of the first people that figured out that maybe pathology in one place of the body could end up somewhere else. And now we know a whole lot more about metastasis, and we'll talk about some of those things in this talk as well. He also was one of the first folks to talk about collateral circulation. He was big into comparative anatomy, and he did, he would ligate carotid arteries of stags and realize that, even though that big branch, that big vessel was ligated, nothing bad happened. So figuring out, collateral circulation and just all these observations that he had has helped guide oncologic surgery for the rest of us over the past several hundred years. One of the interesting things that he noted, a quote here, was essentially that no matter where a tumor or cancer starts, it often works its way towards the skin. So even if you have a deep tumor, oftentimes it'll start working its way towards the skin before it starts working its way into a cavity, which is interesting because, as we'll talk about later, sometimes what we're seeing on the skin is just the tip of the iceberg. And a lot of times that tumor or pathology is seated deep within the skin, into the muscle and into the bone, and then sometimes even into the abdominal cavities themselves. So some of the roles of oncologic surgery, one of the big things that come to mind initially is cancer prevention. And the most common discussion topic there is the idea of spaying our female dogs and preventing essentially breast cancer. And if you are able to spay a female dog before their first heat cycle, they have a 0.5% chance of developing a malignant mammary tumor, compared to greater than 25% if they've gone through 2 heat cycles. So cancer prevention is something that we all play a role in, all the way down from general practice, doing spay neuter clinics and all those things. Another role of oncologic surgery is getting a diagnosis when we do have a tumor. So if we find a patient to present it to us and it has a weird growth, part of the whole surgical process is finding what kind of tumor it is, as well as staging. So identifying, is this a local issue or has there already been spread to other organs, other regions? Primarily the lungs and lymph nodes are typically the 2 major areas that tumors will spread to. Another role that plays in oncologic surgery is just palliation. For example, we have a large tumor in an armpit, and the owners aren't really too worried about anything other than their dog being able to walk better. So palliation is a huge component of oncologic surgery, as well as curative intent, or as part of a multimodal treatment plan. So debulking tumors in large tumors if we're not able to get adequate surgical margins, or in those tumors that we are able to remove completely and essentially cure without having to consider things like radiation or chemotherapy. The treatment of therapy-related complications. So inherently, whenever we're removing tumors, there can be complications with whether healing, especially if they're following up with radiation, or just the disease process itself, such as mast cell tumors having some healing properties that aren't to our advantage. So treatment of therapy and related complications, as well as oncologic emergencies. So as a veterinarian, sometimes we have an oncologic emergency. The most common one that probably comes to everyone's mind is the case of a hemoabdomen. The vast majority of those cases involve a tumor in the abdomen, most commonly the spleen. And we take the role of oncologic surgery to remove that source of bleeding and treat the life-threatening ailment. So there's a lot of roles of surgery when it comes to oncologic principles. So going kind of back to the beginning, starting off with getting a diagnosis and staging. So one of the first things that we need to figure out is what kind of tumor are we dealing with? And we find that out in kind of a progressive order of invasiveness. The place to start typically is with an FNA or cytologic techniques. So FNAs are consistent with histopath results in about 80 to 90% of cases across the board. Now we know there are some cases where cytology doesn't fit with histopath commonly, such as soft tissue sarcomas because they do not exfoliate well. But other tumors, even like mast cell tumors, there's some attempts to start grading mast cell tumors simply off of fine needle aspirate. And so getting the diagnosis first is going to help guide us in terms of whether we need to go forward with a biopsy or whether we can consider an excisional technique. So next step is talking about the biopsies, and there's several types of biopsies that we'll talk about, including incisional, punch, and biopsies are going to give us a bigger sample, which will often give us a better idea of what the tumor is, as well as allowing us to grade most tumors. And getting a grade on a tumor is very important because grading a tumor will allow us to know what type of margins we should expect, what type of prognosis we should expect. There's a big difference between a low-grade soft tissue sarcoma and a high-grade soft tissue sarcoma. So being able, again, to set that client up with a realistic expectation moving forward when it comes to getting the diagnosis. And then finally, excisional techniques. These can be all the way from an excisional biopsy, when you have that 2, 3, 4 millimeter mass on an animal side, and when you've done a little in-house FNA, and you've deemed it, you got a really good chance of getting adequate margins on this tumor, but still, we should submit that tumor to make sure it is what we think it is and help, again, make sure we got clean margins and things like that. So a little more specifically, cytology can be an FNA. It can also be a cytology of fluids, such as abdominal fluid or thoracic fluid. Sometimes those can be neoplastic in origin, and as well as even impression smears. So if you have a mass that has a little bit of ulceration or things of that nature, you can do impression smears and send those FNAs out. And I do think it's always a good idea to send it out to a clinical pathologist when you're able to, and if the client's able to, because it's always helpful to have those people verify what we think we're seeing underneath the microscope there. So what we're seeing here on the slide is actually a spindle cell. Again, typically spindle cell sarcomas do not exfoliate really well, but we got one on this sample here. So getting samples with just a little needle is going to be very beneficial because, again, there's a high correlation with histopathology, as well as it's minimally invasive. Most animals, you can do it with them wide awake. And most of the time, the turnaround is pretty rapid, within a day or two, whereas other techniques do require a lot more fixation and processing. So the next thing is talking about biopsy. So why, if we have an answer from an FNA, do we go with the biopsy? Again, it's just to help us with surgical planning and to help us figure out exactly the grade of a tumor and things of that nature. And nothing is 100%, even biopsies, but again, the correlations with final histopathology results are very, very high. And one of the key things about biopsies is often we're able to get a mitotic index. And this paper here kind of shows the correlation of mitotic index with longevity. So the 3 columns are less than 10 mitotic figures, 10 to 19 mitotic figures, and greater than 19 mitotic figures. And what you can see there is that essentially the more mitotic figures are present on a biopsy, essentially means the more aggressive and rapidly replicating that tumor is. Oftentimes, as you would expect, a more aggressive tumor is going to have a shorter median survival time. So getting that is, again, a good way for us to prep the owner for a realistic expectation moving forward. And these are all things that we have discussions with the owners about. And some owners just want to get it off and be done with it. But those owners that are able to move forward with getting all the information that we would like will definitely help make your surgical planning better. If it comes to us, making our surgical planning better, and just allowing everyone to be as well informed as possible, because it's best when we can, gather as much information as we can before any surgery, especially oncologic surgery where margins and things play a huge role. So when it comes to tumors, doesn't matter what it is, our best chance at getting a good outcome is going to be the first time. So having the results of the FNA, having the results of the biopsy will allow us to appropriately plan for the tumor removal. So, and that even includes, in-house. So if you have your biopsies and you have your FNA and it's a mast cell tumor, and that you got to get, relatively good sized margins, but it's on a lateral thorax with lots of extra skin, then that helps you with that surgical planning and making sure you're able to, hopefully, again, curative intent, getting a tumor with good margins. So as much information as possible before the big surgical procedure is always helpful for both you, the client, and most importantly, the animal. So again, it does often come back to the role of surgery in certain cases. Is this a palliative surgery where we're just debulking a tumor to help with ambulation? Are we debulking a tumor to help improve our outcomes with radiation therapy and chemotherapy? Or are we planning to cure the tumor by removing it completely? So preoperative imaging is important. Sometimes in special occasions, advanced imaging like CT is very much indicated, especially again with our soft tissue sarcomas and our fibrosarcomas, which again often are a lot more invasive and can go through multiple fascial planes, as well as giving you an idea of the excision that you need to plan and giving you a chance to review your regional anatomy. So it's always a good idea when you're working in certain parts of the body, even as many times as we do these, it never hurts to review your anatomy, your local anesthetic possibilities in terms of regional nerve blocks, creating the best environment to have a successful outcome. And in some cases, it also allows you to plan your reconstruction techniques. So should you need a flap of some sort, should you have to consider open wound management at the end of the day, or also again, allowing your client to have the expectations. So when you have a tumor that's on a distal limb and it's a relatively, medium grade, and you think you're going to have to either manage it as an open wound, which is the case from time to time, or if you think there's a flap that could be performed, those are all things to talk about with the owner, as well as giving them realistic expectations of survival of those flaps. If you're going to do open wound management, how long it could take for that wound to close, prepping them for the additional, bandage changes and hospital visits. Again, just allowing everyone to get as much information about the tumor as possible. And again, helping the patient with the best outcome possible. So what happens when we don't look before we leap and we just, again, as I mentioned, sometimes do an excisional biopsy, first chance is always the best chance, because after a surgery has happened, a lot of things are changed. Sometimes a curable tumor is not cured, and that's kind of the worst case scenario. We can also seed previously non-invaded tissues. So doing surgery, inevitably, you may go through some of the tumor and then you go through some healthy tissue, and you could be seeding that area. Again, because we didn't know what kind of tumor it was, our margins weren't as they should have been. And so we can sometimes seed other areas. Also, a big problem can be loss of normal anatomy. So muscle planes, fascial planes may be disrupted, such as in the case here where a mammary tumor was removed and we have recurrence, caudally there. So, now we have lots of scar tissue, which is going to make repeat surgery more difficult, both from identifying appropriate planes, hemostasis, muscle dissection, all of those things. So the less normal tissue present also can sometimes affect our closure. So we can take what would normally be a routine closure, and now there's a bunch of scar tissue, fibrous tissue. So now our closure is no longer routine, and we may have to consider reconstructive techniques. And oftentimes the second surgery is even bigger than the first surgery. So even though this dog had a couple of, it looks like a couple of our caudal mammary glands removed, now this time we have to get good margins. We have to remove the entirety of that scar and then some. So having repeat surgeries often does lead to, number one, increased morbidity because we have a larger surgery and we have to resect that scar as well as the extra dissection and things. So if at all possible, the best chance of curative intent is going to be the first time around, and having all that information with your preoperative sampling will do nothing but increase your chances of chaining that goal. So these are kind of 10 guidelines that Dr. Spodnik has come up with in terms of getting a diagnosis of cancer. And it pretty much starts with, minimally invasive up to the more invasive. So, put a needle in it first. By far and away, it's an easy thing to do. We have good correlation with final results of histopathology and FNA. Most patients don't mind it too much. And so, the first thing first is, put a needle in it. And the other consideration, even if you're doing an excisional type of biopsy for a small tumor that you're able to get adequate margins on with a pretty easy surgery, if it's worth cutting out, it's worth submitting. So if at all possible, encourage everyone to submit those tumors, even if we think it's a little benign follicular tumor or something to that effect. It's best to get those results because sometimes we can be surprised. So if it's worth cutting it out, it's worth submitting. So biopsy procedures do not negatively influence survival. Some people may think that, by doing a biopsy, and we'll talk about other techniques in a bit, whether it's an incisional or a Jamshidi or whatnot, they have a perception that, we're going to anger the tumor, so to say, and that's not the case. Studies have been done that have looked at whether survival rates or any of those things have been affected by biopsy, and they're not. So a biopsy is not going to negatively influence the final outcome of a surgery. If anything, it's going to, again, help with the final outcome by giving us more information. So bigger is often better. Again, the bigger sample that we can obtain, the more we can give the histopathologist, the better chances of getting an accurate diagnosis as well as a grade. So one exception to that rule is going to be bone tumors. So we don't want to take a bone tumor and take a huge chunk out of it, because then we can lead to pathologic fracture and things of that nature. But in general, the bigger sample that we can get, the better in terms of getting an accurate diagnosis. Avoid obtaining biopsies from ulcerated or necrotic tissue. We talk about getting that junction between normal and abnormal tissue, but we do want to avoid typically the middle of those lesions, especially if they're necrotic or ulcerated, because then we're just going to get biopsy results back with a bunch of inflammation, scar tissue, those kinds of things. So avoid those necrotic areas when we are getting our biopsies. Planning ahead, again, getting the information ahead of time, reviewing our anatomy when relevant, and making sure we have a plan should things go not as expected. Maybe we think we're going to have plenty of room to close it, but we don't. And we have to consider some of those reconstructive techniques. Another thing is handling your specimen with care. So getting our sample out of the body. We don't want to do a bunch of undue trauma to our sample. We want to have a nice, clean, even plane dissection. And when it comes out, we want it to be nice and tidy. We don't want to have lots of extra cuts and scars and those kinds of things, which may make the pathologist's job more difficult, especially when it comes to giving us margins. So X marks the spot. Again, having their area that you're removing, which is the tumor itself, as well as the surrounding area based off of the tumor type and whether we should consider, larger margins, minimal margins, so on and so forth. Fix it. So every time we should know that, once we get the sample out, there is a finite amount of time before we should be able to get that in formalin. Roughly a 10-to-1 ratio is the recommendation. And sometimes we do have to actually cut up or bread loaf the specimen should it be too large. The average penetration of formalin is about 1 centimeter. So when we do have a whole organ that we're submitting, such as a spleen in one of those surgical emergencies, it is a good idea to bread loaf those samples. And if you do have a larger, tumor sample, we do need to, prepare it appropriately so that the formalin is able to penetrate and get to the areas it needs to fix before autolysis and necrosis start to set in, which again can alter our histopathologist interpretation of the results. And also remember your pathologist's birthday. It's never a bad idea to set up or try and develop a relationship with a specific pathologist. I know a lot of times it's easy just to send it to IDEXX or send it to Antech, and you never get the same report read by the same person more than twice, and there's no relationship there. But if you're sending out a lot of samples and you find a pathologist that seems to work well and you like the way they write, and we're able to request certain pathologists when we submit these samples, and you can develop a relationship. And it's funny, Dr. Spodnik and myself both had a little bit of a relationship with Dr. Barb Powers when she was over at Colorado State. When I was in Memphis, we sent all of our samples to Colorado State, and if we had issues, we could call Barb Powers, because she was kind of a head of the department there, and chat with her directly and say, hey, we were kind of expecting XYZ. Your resident says this, can we double check and make sure? Those kinds of things are important, because again, it is important to have an expectation with your sampling. And if you get something that's just doesn't seem to vibe, having that relationship with a pathologist makes it that much easier to get it all figured out. So getting on to some of the biopsy techniques that are out there: incisional, needle, punch. Pictures on the bottom left, there's a Jamshidi needle that's typically reserved for bone. It's going to be able to penetrate the cortex of the bone and create a bit of a core sample for you. Trefines, again, very similar to just penetrating through tissues, and then you get a nice core sample within the actual lumen of the tube there. And then TrueCut needles, these are often 14, 16 gauge needles that have a slicing mechanism where you can penetrate deep into the abdomen in some cases. Should you want to get a sample of a liver or a spleen or something, you can utilize that in ultrasound to get you a nice sample. Incisional is what we often think of with cutting off a small piece. So if you have a big tumor and getting a good chunk of it to send off to the pathologist before deciding your primary repair. There's not a hard and fast rule in terms of how big of a sample you should get. But again, the biggest sample that you can get that is not overdoing it. We don't want to create increased morbidity. We don't want to have trouble closing our biopsy site. But if we can get a nice chunk of that tissue, a nice wedge, definitive wedge, that's just going to be able to get us the information we need to plan a good surgery on that patient. You can see a punch biopsy being used in the upper right-hand corner of your screen there, and that looks like a liver to me coming out of the image there. So punch biopsies are also good tools. They come in varying sizes, ranging from 2 millimeters up to 10 millimeters, and they may even be bigger than that, some of them. So getting a good punch biopsy is often really useful. I like to use punch biopsies a lot on abdominal organs, such as liver biopsies after splenectomies and things. A lot of times in the skin, I do prefer to go with the incisional type. So guidelines for incisional biopsies is, again, as big as possible. Sample a couple of areas if possible, avoiding those necrotic tissues. Again, if you have a big ulcerated component, avoiding that area. So when it comes to bone tumors, they're the exception to the rule. Bigger is not always better. And also those are tumors that you do want to get the middle of the tumor. bone tumors on the periphery will often just give us a result of inflammation or reactive bones. So getting good samples from the bone is typically going to be getting the middle of the lesion. And there's actually a really high correlation between FNA samples versus biopsy samples, even of bone. So if you have a suspect osteosarcoma lesion, again, it's a lot easier to take a 18 gauge needle and get a bone sample that way compared to having to really heavily sedate an animal and use a Jamshidi, which again is going to be a bit more painful for the animal. And again, the biopsy results and the histopath results and the FNA results of those samples are often very high correlated, greater than 85–90% of the time. So bone tumors, again, we're going for the central aspect of the lesion. The rest of our skin tumors and things, we're often going for, again, that junction of normal and abnormal, avoiding the necrotic foci if they are present. Other things about biopsies is when you're doing your biopsy, we have to plan ahead for the possible surgery to come. So if we're doing a biopsy of a large thigh mass that may end up in amputation, we have to remove the biopsy tract. So in those cases, it's best to come from a direction that will allow easy resection. So if we have a bone tumor of the proximal femur, I've seen this before, unfortunately. A biopsy was obtained from dorsal, so just next to the ilial wing almost up there, and we had to then resect that area as part of our amputation. Whereas if we had gotten that sample from further down the femur aiming proximal, resection of that would have been a lot easier. So keep in mind when you're getting your biopsy sample that should you have to do surgery and should it be an amputation or even an excision, that we have to remove those biopsy sites. So again, planning ahead for that. And the same thing goes with, for whatever reason, if we have to think about putting a drain in something or whatnot, those draining sites also have to be removed. And again, always handle your samples with care. So we want to be able to get those samples not macerated and things of that nature. And if we can, avoiding cautery, because cautery chars and burns, and that can alter the interpretation. So again, a bone tumor example here, the right side is showing how we're kind of going directly into the middle of the lesion. And the yellow dots on the left are kind of areas that you want to avoid. The cranial part of the bone there is going to be all reactive. The proximal aspect, the distal aspect are all going to be just reactive bone. But if you're able to follow the guide of the Jamshidi there, being able to get those samples from the middle. So again, bigger is better, except for osteosarc. So it's always a good idea to get a post-op x-ray after your Jamshidi. Again, FNA samples, less of a concern here, but we can cause pathologic fracture in these dogs. So again, using some judgment there. And if you do use a Jamshidi, it's always best to remove the sample from the handle, so to say. These needles taper. So if you were trying to push that sample out the end of the needle that you put in the dog, you're going to crush that sample. You're going to, mess up that sample. So we do always actually, take the little shepherd's hook and go from the distal to the proximal part. So pushing it out through the handle area. And so excisional biopsies sometimes can be the way to go, such as, we've done a FNA on this, and we know that this is a mast cell tumor. We don't have to go with the biopsy here. We know that the best thing to get it to do next is going to be getting the tumor out of there. And given the location, a complete penectomy in this dog was able to get us the results that we wanted. So again, in this case, it was a mast cell tumor. So we knew that given the location on the base of the ear, really the only option we had was complete penectomy. So, we all like to have strict guidelines, but oftentimes we do have to use our own judgment for these guys. So this little dog did very, very well without that little ear there. Again, this tumor on the left is a necrotic soft tissue sarcoma. We would want to avoid that area in the middle that's all black and dark and necrotic. And also on the right, we have an oral squamous cell carcinoma. Again, trying to find that junction of normal and abnormal, because again, a lot of this is just proliferative granulation tissue at this point. So trying to optimize our results and getting a good sample so we don't have to do repeat sampling. So now we have our results and we got to start thinking about staging the tumor. Once we have a definitive diagnosis, or even at the time of sample collection, we can consider things like regional lymph nodes. It's never a bad idea if you have a tumor that you suspect of being a malignant type of tumor to try and identify the regional lymph node. And general rule of thumb is work your way towards the heart. So if you have a tumor on the distal foot, the next lymph node is going to be the popliteal. So work your way back towards the heart, and you're typically going to run into the draining lymph node. There are some exceptions to that rule, but those are typically to do with the thyroid and things. So we don't have to talk about that too much. So having a sample of the thyroid, whether it's removing the lymph node at the time of surgery, or whether it's an FNA of that tumor or that lymph node, is always a good idea to consider as well. So surgical margins, again, using the information that we were given on all of our preoperative diagnostics, helps us guide tumor size and resection. And oftentimes, getting good margins, it has to do with the size, and also considering your fascial planes deep. So if we have a mast cell tumor, there are some papers that talk about getting margins the size of the tumor itself. Sometimes that's impossible, and there are other papers that state that 2 to 3 centimeters is often great for getting those margins that we want. And also having the ability to ink your tumors just does a great job of allowing the histopathologist, again, to tell you what your margins are. So if you're able to ink your tumors, that does nothing but help the pathologist identify the actual margins, especially when there's layers of fat, especially when you're trying to get a good fascial plane. Inking is a great thing to do, and typically the darker the ink is better. So they have all sorts of colors like yellows and stuff, but really the violets and the blacks and the dark greens are typically the pathologist's preference. So again, this is a representation of getting a good fascial plane. The thing that we often miss on tumors is that deep fascial plane. So on the left side of the picture, you're just kind of scraping the tumor off of the fascial plane that's deep, whereas the picture on the right incorporates that fascial plane. And oftentimes fascial planes are pretty readily distinguished once you can get beneath the fat. So if you're removing a tumor and there's just a bunch of fat around it, clearing that fat away and finding that shiny white fascial plane is often going to be the way to go. So including our deep margins is critically important, especially in our more aggressive tumors like mast cell tumors and soft tissue sarcomas. When it comes to surgical margins, again, we can have considerations for marginal excisions, which are just right around the tumor. Wide excisions, again, based off of the tumor type, whether we're considering 2 centimeters, 3 centimeters or more, fascial planes and things of that nature. So having the margins and getting proper margins based off of the information provided is going to, again, help us get the best outcome possible. So there are different types of surgical margins. Intracapsular means that we don't remove the entire tumor because we're going through the tumor capsule, and that would be considered debulking. If we know that we're cutting through a tumor because it's a big tumor and we can't get it all, and we're just, again, debulking it for palliation or to help increase our chances of radiation being effective or chemo being effective, those things are considerations. Marginal would be just essentially removing the tumor and its capsule itself. Not a whole lot of extra skin there. And when we have our little benign epithelial or fibro tumors that are just, sebaceous glands or other things of that nature, getting that marginal excision is perfectly reasonable. Wide tumors, for tumors that we know are aggressive, our mast cell tumors, our soft tissue sarcomas, fibrosarcomas, those types involve removing the tumor in its entirety, as well as a healthy margin of normal tissue, because again, sometimes that disease spread can be macroscopic. And then radical excision are things like amputations. So when we have a osteosarcoma, the distal radius, or we have a big mast cell tumor that we've identified as a high-grade mast cell tumor in the distal leg, the best thing to do oftentimes in those cases is a radical excision, and that's often centered around amputation or hemipelvectomies or other much more invasive procedures. So surgical margins, again, benign versus malignant is very important. Benign tumors, oftentimes we can go with that marginal excision and minimize the morbidity to our patients. But when we do have malignant tumors, that's where grade comes in. And, surprisingly, there's some research that shows that in low-grade tumors, like low-grade low-grade soft tissue sarcomas, even if we don't get all the tumor, we can have a pretty good chance of not having tumor recurrence. So again, being able to set that owner up for that expectation. And the paper on the right is talking about the mast cell tumors. Again, if you're able to remove a mast cell tumor with the same margins as the size of the tumor, your chances of getting that in its entirety are pretty good. So again, always remembering that deep fascial plane. It's not always about laterality. We also have to get the appropriate depth, and tumors spread easily through fat. So getting down to that fascial plane, that deep well configured collagen will help prevent some of that tumor from penetrating through there, and getting that plane will just improve our chances. So this is one thing that is pretty interesting that we all see. We say we have a tumor and we're going for a wide resection, and we get our 2 or 3 centimeters, and then we notice that our tumor in our skin looks like it's shrunk, and it indeed has. Through contraction and everything else, and through processing steps. Essentially, every processing step that the histopathologist does creates a shrinkage effect of that tumor sample. So we have to consider that, especially when we're trying to figure out if we got our good margins, because oftentimes our margins will come back as small, 1 millimeter, less than a millimeter, and we're sitting in our minds thinking, I removed 3 centimeters around this tumor. How do I only have 1 millimeter margins? We have to consider the fact that we indeed have a lot of shrinkage during the processing. In this paper, it describes up to 8.8 millimeters between processing steps in some mast cell tumors, and up to 5 millimeters between processing steps in some soft tissue sarcomas. And even some of the larger samples had a reduction in size of up to 3 centimeters. So say you thought you got a 4 centimeter margin, and then by the time you get it to the histopathologist and all the fixation is done, it's only a centimeter, and then you have a 1 millimeter margin. So remembering that physiologically there is going to be some shrinkage of the samples once we collect them. And then biopsy evaluation. So most reports are going to come back with margin evaluation. Mitotic index, again, is a huge thing to let us know about prognosis, because that's, again, how aggressive and replicative this tumor is going to be. Tumor grade, again, helping us with tumor planning. Is it a low grade, high grade, grade 1, 2, 3? And oftentimes, using that information and then just pulling a recent paper will give you the best idea of those sources. It would take a whole nother talk just to talk about, we have a low grade mast cell tumor, high grade mast cell tumor, grade 1, 2, 3 soft tissue sarcoma. So, being able to reference that and developing a plan for that patient, as well as local invasion. If you already have signs of vascular invasion or lymphatic invasion, that can help, again, let us know that it's possible that this tumor has already started spreading. Hopefully, in certain cases with certain suspicions, we've already gotten a sample of that regional lymph node, which will help, verify. And then always considering removal of that regional lymph node at the time of primary surgery is also a consideration there. And then anaplasia and differentiation. So, is it a well-differentiated tumor? Is it well organized, which is, typically a better sign than a poorly differentiated or unorganized. Sometimes they may not even be able to give us definitive answer because the tumor itself is so disorganized. So so that's kind of the start of getting to your surgical procedure, is getting all the information that you can, and typically a stepwise fashion of FNA to biopsy to surgery. And again, we're all limited in what we may be allowed to do by the owner. So, using the information provided to give yourself the best information that you can to allow for the best surgical planning and outcome for the patient is what everybody's goal is. So, so that's going to be it for my part of the discussion. Dr. Spodnik is gonna take over for the remainder. Thank you guys for your time.
I have one question. Is there a way to point out things on the slides? Can somebody answer that from Vet Pets Control Center? Hello?
I think so, yes.
Okay, can I manipulate, how do I manipulate the cursor on the screen? I can manipulate mine, but I can't, I don't know if I'll be able to point out things, because there are certain things in the slides that I'd like to bring people's attention to, and you can't, tell me if you can see my cursor moving around right now.
Not right now.
Okay, yeah, there may not be a way to figure that out. All right, what I'll try to do then is we go through these slides, because there's a lot of case examples of some of the principles that we're talking about here. And so normally I would have a laser pointer or use the mouse to control it and bring your attention to that area of the slide, but I may have to just use some descriptive terms and direct your attention to that. So when I see something that's worthy of mention, I'll try to give you some voice cues as to where that is. But again, the history is kind of interest of mine. And, this guy named Sir John Ericsson was a British surgeon in the mid-19th century. And, he says here that there must be a final limit to the development of manipulative surgery. The knife cannot always have fresh fields for conquest. And although methods of practice may be modified and varied, and even improved to some extent, it must be within a certain limit. That this limit has nearly, if not quite, been reached will appear evident if we reflect on the great achievements of modern operative surgery. Very little remains for the boldest to devise or most dexterous to perform. So, these were written, 130 some odd years ago. And, I kind of wonder what Sir John Ericsson's view of modern day surgery would be. It probably would appear as different to him as our roles might appear different to somebody, 50 years from now, as this profession continues to evolve. And so, I think it's pretty easy to see that we've made significant advances since the time that he had written this, yet he was convinced at the time that the bounds of what could be done surgically had been met. And, as technology improves, robotic surgeries, whatever, I think we're continuing to evolve our capabilities. And so I think the role that we play today is going to appear as different as the role that Dr. Ericsson played, in the mid-19th century. Guess what? There we go. So, as far as the surgical treatment of cancer is concerned, I think I kind of think about these roles here. There's a chance to cut is a chance to cure. And for each one of these, I'll have cases that illustrate the points, but I just wanted to introduce them in one slide and then talk about them more in depth. So I'm basically just going to run through these quickly and then use clinical cases to point out exactly what I mean by these. As I mentioned, surgery, a chance to do surgery is a chance to cure the patient. Sometimes we'll use surgery in a cytoreductive way in that, we may not be able to completely remove a tumor. Our goal, of course, is to get it to at least microscopic or subgross levels. in terms of, removal of the tumor, but we have not yet completely removed it. But what we're doing is we're potentially making adjuvant therapies more effective. As our role as oncologic surgeons progresses and our treatment of cancer improves, we may be extending life, but at the same time, these patients may be living longer to develop metastatic disease. And in some cases, we may go after that in a second surgery or a third surgery. So sometimes we will excise metastatic lesions. In some cases, and Dr. Brady had referred to palliative means of surgery, certain cases, particularly bone tumors, I consider that a palliative surgery. Sometimes surgery is part of the bigger picture. Again, we realize that we may not be able to cure certain cancers with surgery alone, but it is a vital part of the overall treatment of that patient. And so we think of surgery in terms of being part of a multimodal form of treatment of cancer. Sometimes tumors can present themselves in nefarious ways. And so sometimes these things can present as an acute abdomen, whether it's a hemoabdomen or a septic abdomen or an obstructed airway. We may not realize at the moment that we're dealing with a tumor as the underlying cause. We're dealing with the blood loss or the sepsis or the inability to breathe, yet the underlying problem is a tumor, and yet we still have to deal with these emergencies. In some cases, obviously, after these big surgeries, what I call big cuts, we have to be able to reconstruct the patient in such a way, the surgical wound in such a way that the patient is functional and, if not, somewhat cosmetic. And then lastly, I think, again, as we become more complete in the treatment of the patient in general, we think about ways in which we can provide patient supportive care, whether it's nutrition or pain control. And again, we'll present cases that kind of go over these points specifically. Next slide, please. There are advantages to surgery, and then there are disadvantages. Some of the advantages of surgery, again, in my mind, is chance to cut, chance to cure, opportunity for immediate cure. Obviously, that can't be achieved with all tumors, but again, it does provide us with a way to potentially cure the patient. I also think of it as a non-carcinogenic treatment. Some of the other things that we do, whether it's radiation therapy or chemotherapy, both of those types of treatments can have secondary effects that can produce cancers. I've seen radiation-induced sarcomas develop in some of our post-radiation treatment patients. And certainly, I think we can see other effects, both carcinogenic and immunosuppressive effects of some of the chemotherapy treatments that are available for the adjuvant treatment of tumors as well. And again, they can be, surgery can provide a more effective treatment for large localized tumor burdens. And here again, in this particular slide, you can see that this is a dog that has a large soft tissue sarcoma in the gluteal region. And again, the big cut that you see here was based upon preoperative imaging, which included CT. You can see the extent of the surgical resection. Now, have we completely excised this tumor? Again, based upon what we know about fibrosarcomas and the microscopic spread of cells away from these, the chances are probably not. But we have used this as a way to debulk the tumor and then come in and follow up with post-surgical radiation therapy. Okay. Oh, one other thing, well, go back to that previous slide. You can see that there is a drain. You can see the Jackson Pratt drain that's in the patient on that right-hand picture. And again, if we are doing a surgery like this, again, one of the things that Dr. Brady had talked about was planning ahead. and, just placement of the drain. So keep in mind that I'm going to try to exit that drain because obviously it's necessary in this case due to the dead space that's created by the dissection, but we want to make sure that that's exit wound is not placed too far away from the primary incision so that it can be included in the radiation field, because the assumption is that when we place that drain, if there are any tumor cells that remain, microscopic cells, as we place that drain, we could drag them out through the soft tissues, and they can be anywhere along that track where the drain exits. Okay, next slide. Disadvantages of surgery, obviously, there can be morbidity and mortality. And I tell people that I have complications just like the rest of you, except when I have them, they're usually bigger, more severe, and they are generally more expensive. And so here you can see a tumor resection gone poorly, where it dehisced after and probably became infected after a large sarcoma was removed from the lumbar region of this particular patient. So certainly these can be associated with a huge degree of morbidity, certainly mortality, and certainly expense to the owner. On the slide on the right, you can see that there was a tumor that had been excised on what I call the cubital area. It's just the cranial aspect of the elbow. And although it healed well, you can see that there was a certain degree of tension with that wound closure, as evidenced by the cicatricial scar formation that's there, and limiting the dog's flexion and extension of the elbow. So, we can see alteration of normal anatomic or physiological functions with our surgical interventions. And so these are things to be mindful of and counsel owners on. And of course, these are going to vary depending upon the area of the body that we're working around. So for example, if there's an anal sac carcinoma, one of the things that we're going to certainly counsel owners about in that area is disruption of the protector of the dignity of the dog, which is the internal and external anal sphincters. And so, speaking about things like potential fecal incontinence would be a significant thing to consider. So these are going to vary depending upon where we're located. And as Dr. Brady had mentioned, being aware, anatomically aware of where you're operating can, help you be mindful during the surgery and help you counsel owners as to what, the expectations of potential complications and risks might be. Okay, next slide, please. I love this slide because this is the only chemotherapy as a surgeon I need. It's the only thing that I know that instantly kills all tumor cells. Obviously, I say that with tongue in cheek, but, one of the goals of treatment, surgical treatment of cancer is that a chance to cut is a chance to cure. And again, formalin is, I think, a surgeon's form of chemotherapy. Next slide, please. Here's an example of what I'm talking about when I say a chance to cut is a chance to cure. This is an 8 or 9 year old Doberman pincer with a rather large acanthomatous epulus. I think this tumor is now called an amyloblastoma, but it is one of the 3 apulides. Remember, there's ossifying epulus, a fibromatous epulus, and the tumor formerly known as an acanthomatous epulus, or now the amyloblastoma. These tumors are 100% benign. They never spread, but they can be very locally aggressive and destructive. And here you can see that this tumor is actually, I don't have a picture of the CT, but on CT, this tumor was actually invading and destroying the bone. And as you can see in that upper left-hand slide, you can see displacing some of the normal dentition. That 4th premolar there is significantly displaced laterally. The CT helps us to determine the extent of the surgical margins. And we know that with this particular tumor, if we can stay a centimeter away from the edges of the tumor, we can probably cure this. And so here you can see that a segmental resection of the jaw was performed, the mandible, in an effort to maintain functionality of the mandible. That lower left slide shows a graft of an autologous rib graft wired to and held in place with a reconstructive plate applied to the mandibular shaft. And then in the bottom right-hand slide, you can see that there's been an addition of cancellous bone, the reddish granular material below the plate, below the rib there, is cancellous bone that was harvested from the proximal humerus on that side. Next slide, please. So here you can see the closure from the oral aspect. So this resection was done through a ventral incision on the mandible. The beauty of this is that here you can see in that lower left-hand slide a picture of the dog's occlusion 1 day post-operatively, the radiograph, and you can see the dog pictured there. You can see the bandage over the rib, over the thorax where the rib graft was obtained. And if you look closely over this proximal left humerus, you can see an incision where the cancellous bone graft was obtained. And you can see in the lower right-hand corner of that picture on the bottom right, his meal, which he was eating day 1 post-op. That's a case where we can cure the tumor, and that dog went on to die of other causes. Next slide, please. As I said, sometimes tumors can be so large or in a location that are not feasible to permit complete resection, and so the best that we can hope for sometimes is to cytoreduce the surgery so that our other treatments, whether they be adjuvant chemotherapy or radiation therapy, have a better chance at having some type of effect. Remember, especially with radiation, this is a large soft tissue sarcoma, again, at the base of the tail, extending up into the lumbar region. Again, these tumors, as they get this large, they develop areas of hypoxia, and we know that hypoxia can decrease a tumor's sensitivity to radiation therapy. And so if we were to simply irradiate this tumor, even preoperatively, there would be regions of this tumor that would be unfazed by the radiation. And so in this particular case, it was elected to see if we could debulk this tumor. Again, I'm not vain enough to believe that I can surgically cure this tumor. Even though it looks pretty clean in that lower left-hand photo, and what you're seeing centrally there is probably the first or second coccygeal vertebrae where the tail was amputated, and just below that, you can see the anus. Even with that kind of a big excision, we're still probably leaving microscopic disease behind, but that's the type of disease that's going to be most effectively treated with our adjuvant therapies. And so that's the goal of a cytoreductive therapy, is to make our adjuvant therapies more effective. And again, in that lower right-hand slide, because we know we're going to follow up with postoperative radiation therapy, notice where the closed suction drain, the Jackson-Pratt drain exits, it's very close to that proximal or cranial incision, so that we don't, it will be included in the radiation field. We don't have to make the radiation field any bigger to include an errantly placed drain tract. Next slide, please. As I mentioned, sometimes, our therapies, as we get better and better at treating cancer and improving survival times, median and disease-free survival times, we alter the biological behavior of the tumor. And although lung mets are fairly common still, these dogs are living long enough to develop metastatic lesions in places that they normally wouldn't. They would have succumbed to, let's say, a pulmonary met before their kidney, became affected with a tumor. And this is an example of a dog that had a osteosarcoma. The dog was treated with, it was an appendicular osteosarcoma. I can't remember which limb it was, but the limb was amputated. The dog was treated with postoperative chemotherapy. I believe in this particular case, it was carboplatin. The dog survived well beyond a year, and then developed some blood in the urine, and on further evaluation realized that the dog developed a kidney metastatic lesion. And so there are some criteria for metastasectomy. So if these dogs have long disease-free intervals, in the case of osteosarcoma, there was a study that was done of greater than 300 days. They only had one metastatic site, and there was a long doubling time in the tumor. Those are dogs that generally will tend to do well with resection of those metastatic lesions. Next slide, please. But again, I think I just said that, so I'm not going to revisit that. That's what this paper was on the left. This was a veterinary surgery paper. It's a bit dated now, but this was written by one of my resident mates, Maura O'Brien, and was a paper out of Colorado State. And they specifically looked at 36 cases of, in this particular case, they were pulmonary metastases. The one that I showed you was a case that I had seen a few years ago, and it was a renal metastatic lesion. But again, those criteria kind of apply no matter where the metastasis is. There's also a report of a dog that had an appendicular osteosarcoma, and there were multiple lung lesions, and they used video-assisted microwave ablation of the lesions. This is kind of a gee whiz. This dog did not survive for a very long time after that, but the primary thing is that, as you know, dogs with pulmonary lesions can develop hypertrophic osteodystrophy. And the problem in this dog, although the dog was doing quite well, even with the pulmonary metastasis, there were no pulmonary signs. The dog developed these hypertrophic osteopathy lesions and was quite lame. Interestingly, after the treatment of the pulmonary lesions, the HO got better and the dog had a period of time in which it was comfortable. But it wasn't long after that. I think it was 136 days later, the dog either died or was euthanized as a result of progressive disease. Next slide, please. Again, as Dr. Brady mentioned, sometimes surgery is palliative. We know that we are not going to cure the patient of the cancer, but we are going to improve that patient's quality of life, whether it's because of pain or some other issue that the dog is having. If it's a big, ulcerated, necrotic, nasty, infected tumor, we may not be able to cure that patient with surgery alone, but we're, improving the quality of life by removing that. Probably the best example that I can think of a palliative surgery that we do on a regular basis is amputation for appendicular osteosarcoma. And if you look carefully at that greyhound, it has only 3 legs and it is running about as fast as a 4-legged greyhound. So we can dramatically improve the quality of life of our patients, even with these bone tumors. Remember, these tumors are exquisitely painful. They experience a degree of cancer cachexia. They'll become so painful that they may not eat any longer. They can certainly sustain pathological fractures, which I think if you look carefully in that humerus, you can see that there is a pathologic fracture there. And so these are exquisitely painful. And amputation will dramatically improve this patient's life. Now, we know that at the time of amputation, even with clear chest films, these dogs have micrometastatic disease. And if we do nothing else other than limb amputation in a dog with osteosarcoma, those dogs have a median survival time of about 19.2 weeks or about 5 months. And so the quality of life, though, for that 5-month period is quite good. We know that too, if we follow up with chemotherapy, we can extend that median survival time to about a year. And it doesn't matter if it's doxorubicin or the carboplatin or the platinum drugs, that median survival time is pushed outwards closer to a year. So from 5 months to close to a year. Next slide, please. Again, I've kind of alluded to this already, but this is an example. I showed you a couple examples of cases where we did surgery pre-radiation therapy in an effort to sort of cytoreduce the tumor to make it more susceptible to the effects of radiation and to minimize the scope of the radiation. Here's an example of a thoracic wall sarcoma that had received preoperative radiation therapy, and you can kind of tell, you can actually see the extent of the radiation field. That darker hyperpigmented skin was the area that was included in the field. And so surgery is going to basically go in and completely resect that irradiated field. And again, this was a small enough tumor, but the concern here is that we have, based upon what we know about the growth of sarcomas, these microscopic tendrils that extend out away from the tumor. And so we want to make sure that the surgical field includes all of that. Next slide, please. Again, more of the same. You can see the defect, the reconstruction of the thoracic wall. So this, I mean, you know, this is a big surgery. This involves a chest wall resection. I think you can actually see part of the diaphragm. So in that left-hand slide, below the lower part of that slide is towards the back of the dog. And then as you go up towards the top of the screen, that's more the ventral aspect of the dog. It's the same way as you see it in the patient lying on the table there. And right in the middle there, you can actually see the defect in the thoracic wall, and that whitish tissue is the tendinous center of the diaphragm, and you can see one of the diaphragmatic crura, the circumference of the diaphragmatic crura. So there's going to be a chest wall reconstruction and then a closure of the defect. And here you can see the patient. So again, surgery may be, you know, again, part of a multimodal form of treatment, because we know just by itself, surgery may not be curative. Next slide, please. Onto the treatment of oncological emergencies. As I mentioned, sometimes cancer can rear its ugly head in many ways, whether it's a respiratory emergency, as we see in this particular patient with lymphoma involving the cartilages of the larynx. This patient could not breathe. And so in the meantime, while we are going to rely upon chemotherapy to treat this particular neoplasm, since it is a lymphoma, we can biopsy it at the time, you know, and then but while we're waiting for our biopsy report, you know, and treatment plan, you know, we at least have provided this patient with a way to circumvent the upper airway obstruction. And so this patient has a temporary tracheostomy performed. I took a little bit of poetic or surgical license on this particular case. That is indeed lymphoma of the larynx. This patient did indeed have a temporary tracheostomy placed, and then the tumor was biopsied. Once we did the laryngeal exam, we could tell that there was a mass there. We quickly did the temporary tracheostomy. The patient below is just an example of a tracheostomy. It is not this patient, but it is an example of the surgery that was done in that patient. Next slide, please. Again, other oncological emergencies that you may be faced with. Here we have on the right the classic hemoabdomen associated with a ruptured splenic hemangiosarcoma. We know that we're not going to cure that patient. This patient is ultimately going to die of its disease, yet the interval between the splenectomy and the recurrence of the disease can be good quality life. And so, at the same time, we resolve the issue of ongoing bleeding, and that, so in a sense, I guess this would be another example of a palliative surgery, but at that particular moment, this is a crisis for this patient because of the blood loss, the hypovolemia, the shock, and that patient will die without surgery. So that, I think, is a true oncological emergency, or as pictured in the left, where you can see that there is an intestinal tumor. In this particular case, it happens to be lymphoma, which has perforated and now causing a septic abdomen. And so that can be resected. We treat the peritonitis. Yes, of course, we submit the tissue, as Dr. Brady had mentioned. If it's worth cutting out, it's worth submitting. So again, we've averted the crisis with the resection and anastomosis and the treatment of the peritonitis. And, subsequent to that, we'll develop a treatment plan for that patient based upon the ultimate biopsy. Next slide, please. Reconstruction, you got to have a plan. you know, again, especially with these large tumors, I have plan A, I have plan B, and then I have, oh, well, that was a good try. You know, I always have a couple of options when I'm going into these things, because sometimes even your best well thought out plan, you know, may not translate well once you start to remove a tumor. And here you can see, again, this is a tumor that soft tissue sarcoma, had received previous radiation therapy. You can see the defect immediately after removal of the tumor. And now we're faced with, how the heck are we going to close this? And so you know, we have certain skin flaps that we can use. And here on the upper right-hand side, you can see that this is a circumflex iliac flap, a ventral branch of the circumflex iliac artery that's used to create an axial pattern flap. That entire flap of skin is supplied by an artery and vein, a direct cutaneous artery and vein. And in that lower left-hand slide, you can see the flap has been elevated, and I'm pointing out the pedicle, the vascular pedicle, and you can almost make out the branching vessels as it goes into that underside of the skin flap. And then you can see that that's rotated into the defect, and then the donor site is closed and the flap is sutured into place. And again, you can see the drain placement, and in the lower right-hand side, you can see the dog at suture removal. Next slide, please. Again, you know, some of the things that we need to consider when we're taking off tumors, especially in locations like this, is how are we, you know, how are they going to functionally impair the patient? And here you can see eyelid function is pretty important. We know that if we impair that, we could end up with longer term consequences to, you know, movement of the eyelids, dry eye, things like that, keratitis. And so this fortunately was a benign tumor. It was a fibroma. But again, we want to completely excise it so that it will not recur. In order to do that, you can see we need to make a fairly large excision. And if I were to simply oppose the edges of those incisions, we'd probably permanently keep that dog's upper eyelid from blinking. And so here you can see an advancement flap has been created. That purple line in the upper right-hand drawing is sort of a concentric line that is in size. That skin is undermined, and then it's advanced into the defect and closed. And here you can see the dog at suture removal with fairly good eyelid function. Next slide, please. And lastly, I think, you know, as we go on in our, you know, we've got to pay attention to details. I mean, we can win the battle, but lose the war. And if we're not paying attention to some of the other needs of the patient, whether they be nutritional or pain control, or ways to deliver ongoing treatments in patients that maybe have otherwise poor vascular access. I mean, these are some of the considerations I think that we as surgeons may become involved in. And so here you can see a cat with terrible veins. And this is a cat that's going to be receiving multiple chemotherapy treatments. And you can imagine if every time this patient came in, we had to identify a virgin vein or vessel that we were able to immediately catheterize with ease, that would be one thing. But this was a cat, and we've all seen these patients who are just real challenges to gain vascular access to. And so in this particular case, a vascular access port was placed. You can see this is the jugular, the cervical region of the cat, and we're placing this vascular access port in the jugular vein. The metallic disc has a self-sealing silicone elastomer that can be injected directly through the skin. So you place the port, the injection port, in a readily palpable area. And here you can see it on that right-hand slide. It's placed, you know, up on the side of the neck by the wing of the atlas, and it's readily palpable there. Very easy to access. You can stick your butterfly catheter into that injection port. The metal backing on that injection port prevents you from going completely through it. And the silicone elastomer is resealable. So when you pull the needle out, it's a fairly thick membrane so that it self-seals. The needle going through it won't permanently damage it, provided you use these things called non-coring needles. They're specially designed. Instead of the typical bevel, they have more of a sort of a, almost like a shoehorn effect. They're still sharp at the tip, but they don't core the elastomeric center of the injection port. Next slide, please. Some other things that we do, feeding tube placements, you know, whether or not it's an esophagostomy tube, a jejunostomy tube, or some other enterostomy tube. Again, some of these patients, especially after big surgeries like this, may not be eating. And again, like I said, we may win the battle, but we lose the war because the patient develops some nutritional and immunological compromise and ends up succumbing to some other things that could have been prevented. You know, lastly, you know, pain management. I think we've, you know, come a long way, but things like indwelling epidural catheters, Soaker catheters, things like this. So, for example, with amputation, I'll routinely place a Soaker catheter, a wound Soaker catheter, so that we can instill local anesthetics into the surgical site. So for example, if this is a thoracic limb and we're doing a 4/4 amputation, I'll place a Soaker catheter in such a way that it enters into the wound, and I'll curl the tip around the brachial plexus. And so each time that catheter is injected with bupivacaine, we get very good local control of the cut nerves of the brachial plexus. So these are just some of the considerations that I think, you know, again, surgeons can play roles in as far as the treatment of cancer. I think that's the last slide. Let's just check it. Yep, there you go. Mike Nystrom, I know that guy. Is he working with us?
Yes, he's at Points East as a criticalist there, and he'll be talking on Tuesday, April 27th about fluid therapy.
Oh, I'll be damned.
Yeah, there you go.
Well, I wondered what happened to him. He was at VSH.
Yeah, he's all grown up, married, 3 kids, and now.
Yeah, shut up. It makes me feel old. Really, yeah. You want to know that? You don't want to know when I first felt old. It was when Jim Hummel, a relation of the doctor, you know, our Dr. Hummel. Yeah. He was a student at NC State. When we first started VSH, those many years ago, he was a student who rotated through for an externship. Then he came back and I think spent some time with us. And then I knew I was really getting old when we hired him as an internal medicine doctor. So there you go. Here's another one. I'm getting to it. Yeah. Wow. Well,
that was an easy plug for Dr. Nystrom's talk on Tuesday, April 27th. So please join us then. Again, the CE certificates will be sent out via email this week. And I believe we have one question for Dr. Brady's already prepared to answer that one. And then we'll actually have another one about Nosita as well.
You hear me?
Yep.
All right, so Dr. Watkins asked about shrinkage of margins. Does that mean we cannot have confidence in our margins? Say we are certain we obtain a good margin and yet lab says less than we thought. I replied and I said essentially that a dirty margin is dirty and a clean margin is clean, and a clean margin is a victory, whether it's 1 millimeter or 1 centimeter. If we think that we have larger margins than are indicated, we have to keep in mind that idea of shrinkage. But also we have to remember that sometimes microscopic disease can extend further than we were expecting as well. So it is, again, one of those gray zones. But again, when the pathologist gives you the result of dirty, it's dirty. If it gives you a result of clean, it's clean. So take the clean as a victory.
Another question here is, do you use Nosita?
I'm not sure they were talking about specifically in oncologic surgery. Dr. Spodnik, do you use it routinely in your oncologic surgery as well?
It depends. I think it depends upon the size of the resection. So in some of those slides you saw, those are what I call big cuts. And I love Nosita. I think it's been a game changer in the way that we manage postoperative pain in patients. I think one of the limitations, though, is the volume. So I believe it's 0.4 mils per kilogram of body weight is the number of mils that you need to inject a site with. So if you have a large incision, even if you're diluting that, which you can do, and I think Dr. Lascelles at NC State, I think, has done some work to suggest you can dilute it up to 16 times. That's more than what I would feel comfortable doing. I'll routinely dilute it by twice. So like if I draw up 10 mils and I need a larger volume because I have a larger incision, I'll dilute that up to 20 mils with 10 mils of saline. Smaller volumes, I might dilute up to 3 times, but I usually don't go above that. But the problem is 15 mils doesn't go a long way in a big wound like that. And I think there are probably more effective ways to manage that. And those are the wounds that I'm going to put a soaker catheter in. I don't know if you're all familiar with what a soaker catheter is, but you can manufacture or fabricate one quite simply using a red rubber catheter, like a small one, a 3.5 or 5 French red rubber catheter. I'll cut the fenestrated tip off and actually just tie a knot in it. And then I'll take a red needle, a 25 gauge needle, and make little prick marks in the side of the tube over a length of, maybe 10 centimeters or however long you want. And then you can pull that into the wound. And when you inject your local anesthetic into it, it blebs out of it. It beads out, much like those garden soaker hoses kind of bead water out of them. They're semi-porous, right? And you exit that wound or the catheter from the wound. And I've even sent owners home with those and pre-dosed syringes with the appropriate amount of bupivacaine. And you can inject that catheter 3 or 4 times a day and leave it in I've left them in for upwards of 5 or 6 days. So I think for a very large wound, an amputation, that's probably a better way to go. I just don't think you can get enough Nocita, or you can't dilute it enough to get in all of the tissue planes. I think you're probably going to be better with that. But do I use Nocita? The short answer is yes. I just figure out, is the wound, small enough, or will it accommodate it, or are there other things that I might consider, such as a soaker catheter?
Yeah, I agree with Dr. Spodnik that Nocita is hugely been beneficial for us. And when we're thinking about whether we're going to use it or not, kind of the main thing is going to be the volume, whether we think we can get enough volume in that resected area to be effective, or we should consider other means. So we have another question from Sandra Tucker. She said, I have trouble with the deep plane for margins. So if we have a tumor, then fat tissue, then the fascia, then muscle, do we have to cut into the muscle? You can't separate the fascia from the muscle, right? And the answer is more or less yes. Oftentimes when we get that fascial plane, we do take some muscle with it, just because typically the fascia and the muscle are so tightly adhered. Now, every now and then you can get a nice plane and have minimal disruption to the muscle, but it's more important to get that deep fascial plane with a little bit of muscle than to leave that fascial plane behind and then possibly leave those tumor cells behind. So my experience is exactly the same. I believe that we do often take the fascia with hopefully as thin a layer of muscle as possible.
Agreed.
Does anybody else have any questions for tonight? Really do appreciate everybody attending. And thank you, Dr. Brady, and thank you, Dr. Spodnik, for your time organizing the talk and your time presenting tonight.
You bet.
Welcome, happy to do it.
Well, I think that rounds us out for tonight. Thank you so much, and we look forward to seeing everybody in April.